Hypercalcemia becomes much easier when you stop memorizing causes as a long list. In Part 1, the approach is simple. Confirm the calcium, check PTH, and decide whether PTH is driving the hypercalcemia. First, confirm true hypercalcemia. Total calcium is usually around 8.5 to 10.5 milligrams per deciliter, and ionized calcium about 4.65 to 5.30 milligrams per deciliter, though lab ranges vary. If albumin is low, use corrected calcium. Corrected calcium equals measured calcium plus 0.8 multiplied by open bracket 4 minus albumin close bracket. Once it is truly high, move to PTH. PTH is the key branching test. When calcium is high, PTH should normally be suppressed, so if PTH is high or even normal, that is inappropriately normal, and suggests PTH-mediated hypercalcemia. If PTH is suppressed, think PTH-independent causes, which are covered in Part 2. PTH-mediated hypercalcemia means excessive PTH activity. The main causes are primary hyperparathyroidism, tertiary hyperparathyroidism, and very rarely ectopic PTH secretion. Tertiary hyperparathyroidism usually follows long-standing secondary hyperparathyroidism, especially in chronic kidney disease when the glands become autonomous. Primary hyperparathyroidism is the classic and most common PTH-mediated cause. Think first of parathyroid adenoma, then hyperplasia. Also remember familial causes such as MEN syndromes and rarely parathyroid carcinoma. The biochemical clue is high calcium with raised or inappropriately normal PTH. Now add the calcium-sensing receptor pathway. In familial hypocalciuric hypercalcemia, CASR signaling is reduced, so the body accepts a higher calcium set point. The clue is mild hypercalcemia with relatively low urinary calcium. Lithium can shift the same set point, and rare CASR inhibitory antibodies can do something similar. If PTH is suppressed, the parathyroid gland is not the driver. Then shift to PTH-independent causes. Malignancy, vitamin D or calcitriol excess, increased bone resorption, calcium load, drugs, and rare endocrine causes. That is the focus of Part 2. So Part 1 gives the framework. Confirm true hypercalcemia, check PTH, and if PTH is high or inappropriately normal, think PTH-mediated disease. The key causes are primary hyperparathyroidism, tertiary hyperparathyroidism, and CASR pathway causes. Once you understand this split, the table becomes much easier to learn.